Hello again. Let's continue with Chapter 3, Part 2, the medical nutrition therapy for the cardiovascular disease. Let's start. Medical nutrition therapy, MNT, intervention for the cardiovascular disease. MNT is the primary intervention for patients with high cholesterol. Physicians are encouraged to refer patients to nutritionist as the first step, nutritionist or the registered dietitian. A typical successful intervention requires an initial visit of 45 to 90 minutes, followed by 2 weeks or 2 to 6 weeks follow up sessions. These nutrition and lifestyle changes are not just alternatives to medicine, they should continue even during drug therapy to maximize the effectiveness of the medication. Let's look at the specific fats we focus on during these counseling sessions. Specific fatty acid recommendations. We have to be very specific about fats. Trans fats are now recognized as unsafe. They rise the low density lipoprotein and lower, in the same time, lower the high density lipoprotein. So, trans fat increase the bad cholesterol and decrease the good cholesterol. Most come from partially hydrogenated oils. Monounsaturated fatty acids, specifically oleic acid found in olive oil, are excellent substitutes for saturated fats. We also prioritize the omega 3 fatty acids, EPA and DHA, eicosapentaenoic bentanoic acid, and hexanoic acid. The omega 3 from fish oil. American Heart Association recommends eating about 3.5 ounce or 100 gram of fatty fish like salmon, like sardines, twice a week or lower triglyceride and prevent blood clotting. Fats are only half the story. We must also look at the fiber and micronutrients. So, the role of fiber and antioxidant. Fiber is a cornerstone of cardioprotection. Soluble fiber binds to bile acid, forcing the body to use more cholesterol to make new ones, which lowers serum levels. It also produces short chain fatty acids that inhibits cholesterol synthesis in the liver. We also find the antioxidants. Antioxidants also in the high fiber content or a plant rich diet. Vitamin E is particularly important because it is carried in low density lipoprotein particles and help prevent the polyunsaturated fatty acid within them from oxidizing. However, we recommend getting these from whole food like nuts and seeds rather than supplements. If lifestyle changes are not enough, we move into medical and surgical management. Stanols, sterols, and medical management. Plant stanols and sterols are interesting. They are isolated from soybean and pine oil and actually inhibit the absorption of dietary cholesterol. They can be a helpful supplement to sustain therapy. When we talk about medical management, the primary tool are statin or HMG CoA reductase inhibitors. So the block of the rate limiting enzyme in cholesterol synthesis. So again, there's a pharmacological management like statin, HMG coenzyme A reductase inhibitors inhibit cholesterol synthesis. Others, there's a bile acid, 6 strands, nicotinic acid, fibric acid derivatives. There's other classes include the bile acid sequestrant and fibric acid derivatives depending on the patient specific lipid disorders. When a blockage is severe, we move from pills to procedures. Medical intervention for blockages. Percutaneous coronary intervention or PCI, formerly known as angioplasty, uses a balloon catheter to break up plaque deposits. Often, a wire mesh stent is left behind to keep the artery open. In more complex cases, coronary artery bypass graft or CABG surgery is used to bypass the diseased vessel entirely. However, CABG is not a cure for atherosclerosis. The new graft are just as susceptible to plaque build-up as the original ones, which is why lifestyle modification is mandatory even after surgery. Now, let's turn our attention to the silent killer that often precedes these events, the hypertension. So, hypertension is the silent killer. Hypertension is persistently high force against the arterial walls. We measure this with two numbers. There is a systolic blood pressure, which is the force when the heart contracts, and diastolic, the force when it relaxes. As of the 2017 guidelines, normal is strictly less than 120 over 80 millimeter mercury. Stage 1 hypertension now begins at 130 over 80 millimeter mercury. It's called the silent killer because a patient can be asymptomatic for years while their organs, the heart, the kidneys, the brain, sustain permanent damage. To manage high blood pressure, we have to understand the hormonal system that regulate it. The Renin-Angiotensin System, RAS. RAS or Renin-Angiotensin System is our body's long-term blood pressure regulator. When the kidney sense a drop in blood flow, they secrete renin. This trigger cascade that result in angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor. It also tells the adrenal cortex to release aldosterone, which makes the kidney retain salt and water. The increase blood volume and subsequently blood pressure. Many of our drugs, like angiotensin converting enzyme inhibitors, work by interrupting this specific cascade. So, how do we use nutrition to combat this hormonal response? Lifestyle modification is definitive therapy for hypertension. For the biggest factor, sodium reduction, we aim for a reduction of at least 1000 milligram per day, with ultimate goal of less than 1500 milligram for most adults. We also want to increase potassium. Potassium through fruits and vegetables, as it helps blunt the effects of salts. Weight loss also, loss is equally vital. For every kilogram lost, we expect 1 millimeter mercury drop in the blood pressure. For many, these changes can reduce or even eliminate the need for modification. When the heart is chronically stressed by hypertension or plaque, it may eventually fail. In heart failure, the heart cannot provide enough blood flow to meet the body's need. This leads to the hallmark symptoms of fatigue, shortness of breath, and fluid retention. We categorize into systolic failure, where the heart can't pump, and diastolic failure, where it can't fill properly. So, this is the difference between systolic failure and diastolic failure. As the disease progression, the heart undergoes remodeling. It changes shape and enlarge to try to maintain flow. But this eventually makes the muscle weaker and less efficient. In its final stage, heart failure leads to devastating wasting syndrome, cardiac cachexia. Cardiac cachexia is the end stage of heart failure in about 10 to 15% of the patients. It is defined by involuntary loss of at least 6% of non endometous body weight. Unlike normal starvation, which burns fat, cachexia involves the loss of lean body mass, including the heart muscle itself. This is driven by high level of pro-inflammatory cytokines and has a very poor prognosis, a 50% of mortality rates in just 18 months. Our nutritional goal now for these patients are very different from those with simple hypertension. The nutrition management for heart failure. For heart failure, we must be careful. We generally prescribe 2 gram sodium restriction to manage edema. We also limit fluid intake to 2 liters per day because these patients are in catabolic state. Their energy expenditure is actually higher. We need to provide adequate protein and calories to prevent further muscle wasting. We have found that small, frequent meals are tolerated better because they are less tiring and do not cause the abdominal distension that can interfere with breathing. We must also for monitor the deficiencies caused by the modification used to treat heart failure. Vitamins and minerals in heart failure. Medication side effects are a major concern here. Loop diuretics like or any types of diuretics can deplete the body of thiamine, which is a coenzyme required for heart contraction. Supplementing with 100 milligram of thiamine has been shown to improve cardiac function in these patients. We also see magnesium and vitamin D deficiencies. Magnesium deficiency is particularly dangerous because it aggravates electrolyte imbalances and is associated with a poorer prognosis. Coenzyme Q10 repairs oxidative stress. Statin drugs interfere with its synthesis. When all other treatments fail, transplantation becomes the only cure. Cardiac transplantation, post op care. For the heart transplant patient, nutrition is divided into phases. Immediately after surgery, the patient is high stress state. They need increased protein up to 1.3 to 2 gram per kilogram to promote healing and counteract the catabolic effects of steroids. Long term, our focus shifts to preventing complication like excessive weight gain and hypertension, which can lead to organ rejection. We also monitor for steroid induced osteoporosis, requiring optimal calcium and vitamin D intake. To conclude, we must briefly address how recent global health events intersect with this field. Cardiovascular disease and COVID 19. Finally, we must recognize that COVID 19 has a significant impact on the cardiovascular system. Patients with pre existing coronary heart disease had a much higher fatality rate fatality rate over 10% compared to the general average because the virus uses the ACE2 enzyme to enter cells, because cardiovascular disease involves abnormalities in the renin-angiotensin system. It may actually increase the virus ability to enter the lung and heart. This is this reinforces why maintaining cardiovascular health is our most vital defense against modern infectious diseases. Thank you for your time, and thank you for attention, and see you in the new topic in the next chapter, chapter 4. Goodbye.